Hello. I wasn't going to do any of these while I was on holiday, but since everyone has been so fabulously generous with Eleanor's fundraising thing, I sort of feel I have to. So I've been meaning to do one for ages on taking histories. Obviously, the most important times when we take history is when we're in clinic and we see a patient. And certainly all the stuff we're going to go through here is stuff we should do for every single patient that we see. But it's also very, very important when we're presenting cases on here. And there is an exceedingly good reason for that. It's not just a question of us being dickish when somebody asks for help and demanding more information than you have. These things make a huge difference to the clinical diagnosis and also to the treatment plan stroke options. Now, generally speaking, when we think about medical history, there's a temptation, and I've seen this written in notes, to say if the person is healthy, there's no relevant medical history, which of course is nonsense, because the medical history is much more than just what diseases do they have and what medication do they take. So in the post, which should be up there, I've written all this down, and I'll put a clean version with just the headings so that anyone can put them in. So, without further preamble, I've split this into categories because it makes it easier to conceptualize. So the first bit about the patient themselves, we need at a minimum age, gender, occupation, footwear. The age is relevant because there are certain conditions which are infinitely more or less likely in older people or younger people, and if the case is dermatology and all we've got is a picture of a lesion close up, that could be on a 75-year-old or a 7-year-old, and obviously those two people will have different things. So the age is really important. Gender, because there are all sorts of differences in terms of background and history that can be hinted at with the gender. Occupation, because it is a very different business biomechanically. For example, working with a 90-year-old who is living in slippers, or a 40-year-old who is living in steel toe caps and doing 12-hour shifts on a concrete floor, or a 12-year-old who is in school shoes all day. So the occupation is important. And the footwear, which very often is hinted at by the occupation, but not always. What shoes do they have to wear for work / school? Because if there is a requirement, if you're dealing with a legal secretary, for example, and there is a dress code in the office that they have to wear a certain type of shoe, telling them that they have to wear trainers is not going to work any more than it would for somebody who has to wear steel toe caps all day. So as far as the patient is concerned, we need those things. Then we need the medical stuff, and this is what people generally do include, medication and any illnesses. It's pretty straightforward. It's an easy question to ask, and it's an important thing to know. The only reason people don't always include it is they don't understand the relevance. Obviously, there's comorbidities. There's certain diseases which make them more likely to have other diseases. If somebody has a history, for example, of cancer, then we would be more concerned by unexplained lumps and bumps than if they didn't. So that was dead easy, medication and any medical history. And then we've got what for me is probably the most important thing, which is the history of the problem. And this is a bit which is inexplicably often left off. There are all sorts of acronyms for this. I know Ian uses NLDocs. I was trained with Socrates. I've just distilled one down below a little. It doesn't particularly trip off the tongue, but you might find it useful. So first, site. This may seem ever so obvious and banal, but still we get people that don't record it clearly. If it's a dermatology case and it's a nice close-up picture, you might not know whereabouts on the foot it is. If it's biomechanics, it's not enough to say on the side of the foot or on the front of the leg. We need to know exactly where it is. If the pain is non-focal, which will sometimes happen if they sort of wave their hand in a Harry Potter-esque gesture and say it hurts around here somewhere, then you can say that. You can say it's a non-focal generalized pain around the front of the leg. If that's what they've told you, that's what you need to tell us, and that's what you need to record. But we do definitely need to know where it is. Next, we have onset. When did it start? And a few more details that need to go in there. There is when did it start, as in how long ago, and how did it start? Did it come on all of a sudden in the nature of an injury, or did it creep up slowly over a long period of time? Did it become worse over a long period of time? Was there any precipitant factor? Did this come on when they were on a holiday? Were they at a wedding and were wearing a wildly impractical pair of shoes? Did they have an injury? Did they turn an ankle or something like that? Or do they not know how it came on? Next we have the character of pain. So are we talking about a burning pain, a stabbing pain, a sharp pain, a dull pain, a searing pain? We need to have some details of the type of pain. When you're getting this from a patient, a good idea is to describe it in terms, especially with children, of what's it like. So I'll quite often with kids use, you've been stung by a nettle. Did it feel like that? Have you ever had a headache? Does it feel like a headache in your foot? When you've been bruised and you've got a bruised knee, does it feel bruised when it's like that? So try and use examples rather than words. Because children and illiterate adults don't always find it very easy to describe those sorts of things. Then we have associated symptoms, another easy one to miss. Does this come with anything else? Is it swollen? Is it red? Is it blue? Is it white? Is it discoloured? Is it hot? Is it cold? Does it radiate up or down the leg? Does it come with weakness or paresthesia or anything else that is associated with the pain? So that gives us an idea if there's anything else going on in terms of what type of pain it is. And then we've got 3 T's. Really important one, trajectory. Is it getting worse? Is it staying the same? Or is it getting better? This is, again, one of the ones that's often missed and is one of the most important things. If you have an injury, by and large, you can expect it to improve. If you have a dysfunction, by and large, you can expect it to get worse. If you've got something that is environmental, then it may not do either of those things. So is it the trajectory of pain is sort of what's happening to it? Are we talking about something which has happened once and has stayed the same? Is it getting better by itself, or is it getting worse by itself? Then there is treatments. What has been done so far? This is important for a few reasons. First of all, it gives you an idea of what you don't need to do, because if somebody has had a year's worth of salicylic acid on their verruca, then getting them to put more salicylic acid on the verruca is not a great idea. Also, very often, treatments are a diagnostic tool. One of the ways that we can try and work out exactly what something is, if we're not sure, is to treat it for certain things and see if it gets better, or indeed if it gets worse. So if somebody has already used a treatment, that is a big packet of diagnostic information which will be useful to you. And finally, triggers. What is it that in the normal way of things makes the pain better? What is it in the normal way of things that makes the pain worse? Footwear is one of the common ones. Types of activity, time of day. Is the pain first thing in the morning? Is it last thing at night? Is it during the night? Is it when weight bearing? Is it when not weight bearing? Is it after weight bearing? What sorts of things either exacerbate it or improve it? Very often you can almost cheat with these. If the patient tells you that a certain thing helps, then very often we can help them by creating those circumstances. So for example, if they tell you that pain on the top of the foot hurts more when they're wearing a shoe that doesn't cover it, which makes sense, you can help them by showing them how to adjust the laces and do bypass lacing to avoid a bony prominence or something like that. If they tell you that the foot hurts less when they roll their foot in, then maybe make them an insole that will roll their foot in. If it hurts less when they roll their foot out, make an insole that will roll the foot out. So triggers also gives you a big clue in terms of diagnosis. Now, obviously, this is not an exhaustive list, and everyone else will have different questions that they ask, and there will also be subject-specific questions, things which are much more relevant to certain types of presentation. But this, I would suggest, is a bare minimum for any kind of case presentation. And the more information we get from the patients, the more information we can have when we're trying to work out what the problem is, the better advice and the better help we are able to give you, and the better advice and help you are able to give your patients. If it was as simple as what's the best treatment for fungal toenails, what's the best kind of insoles for heel pain, that sort of thing, then there would be no podiatrists and there would be no FHPs. There would simply be a database of X treatment for Y pathology. Unfortunately or fortunately, the human body is a lot more complicated than that, which is why we exist.